For pharmacy, the topic will be pharmacotherapy of diabetes. We are really pleased and honored to have you, Doctor. You're welcome.
Yes, thank you so much, Jasper. I think we have a good number and we can begin, if I may. Okay, yeah, so as introduced, I'm a clinical pharmacist. I work with the Department of Pharmacy. My interests are in non-communicable diseases and mainly chronic kidney disease, but I also encounter a lot of diabetic patients. And also I'm currently doing a research project on trying to make a continuous glucose monitor that is cost effective. So today we shall go through the diabetes, and my focus will be mainly on type 2, but once in a while I'll be hinting on some things that might be of interest in type 1. So DM is a metabolic disorder. We know that from what we've been studying, you know that it has very many etiological causes, but mainly defects in insulin secretion or action, insulin action, in terms of it being sensitive in the tissues, or even both, are the reasons why we normally have blood glucose levels. And we know hyperglycemia is very common. It's a common effect in these patients. And over time, it can cause damage to many systems, especially the nerves and the blood vessels. So for that reason, it is why it is one of the leading causes of eye and kidney disease. And also these patients tend to be at a very high risk of cardiovascular events, like heart failure and atherosclerotic disease. In terms of the classification, the 2024 standard of care of the American Diabetes Association usually classifies them into 4 general categories. We have type 1, which is normally due to autoimmune beta cell destruction. And in this case, we tend to have absolute insulin deficiency, even the latent autoimmune diabetes in adulthood. So before, in terms of categorization, they used to say type 1 is more in the young population, but recent studies have shown that it is actually also very prevalent in adulthood. Then we also have type 2, which is due to a progressive loss of it can be either loss of adequate beta cell insulin secretion or insulin resistance, and also metabolic syndrome. Then we have other types which are due to other causes, like monogenic diabetic syndromes. These are usually things like neonatal diabetes, maturity onset diabetes of the young. Then we have diseases of the exocrine pancreas, things like cystic fibrosis and pancreatitis. And we also have drug-induced, especially glucocorticoid use, or even in the treatment of HIV. We tend to see a lot of drug-induced diabetes. Then we also have gestational diabetes mellitus, which usually occurs in the 2nd or the 3rd trimester of pregnancy. In terms of the signs and symptoms, we have polyuria, the classic. There used to be 3 classic symptoms. but according to the Ugandan clinical guidelines, a fourth one was added. We have frequent urination, that is polyuria. We have polydipsia, that is frequent thirst, and patients tend to drink a lot of water. Then we have polyphagia, the appetite, and polyphagia, increased appetite, and patients tend to feel hungry all the time and more frequently. And then polyneuropathy, patients tend to present with burning pains, pins, and needles, especially in the extremities. There are other symptoms like loss of appetite might also be there. Frequent skin infections like boils. They also tend to present with candidiasis. Their wounds tend to take long to heal, and is a fatigability. So it is very important for us to also note that, especially in patients with type 2, they usually tend to present when the disease has advanced, and we tend to see some of the characteristics. For example, if a patient comes in with diabetic retinopathy, then we can work backwards to the diagnosis of diabetes. In terms of pathophysiology, most of these patients who get type 2 DM have multiple defects in terms of the regulation of plasma glucose. So one is where we may have impaired insulin secretion. For example, if there is an effect on the beta cell, you will have a decrease in insulin secretion, and then all that can lead to hyperglycemia. Then we also have deficiency in incretin hormones. These are hormones that are usually produced in response to ingestion of a meal. So what these hormones do is that they first of all, they can decrease the effect of glucagon secretion, which is a counter-regulatory hormone, and then also enhance insulin uptake of insulin by the cells. So if there is a decrease in incretin, the incretin hormones, that is the glucagon, mainly the glucagon, like peptide 1, then we may also have a scenario of hyperglycemia. Then the other thing, obviously, is the insulin resistance. That can be in either the muscles or the liver or in the adipose tissue, because of regulation of the receptors. And then we also see excess secretion of glucagon as well. We also see increased hepatic glucose production in these patients. And also an important one is the upregulation of the sodium glucose. Just a minute. So an upregulation of the sodium glucose co-transporter in the kidney. So this co-transporter is responsible for reabsorption of glucose. So if there's an upregulation, that means you'll have more glucose in your blood. And you can see that's why some of the drugs are targeting these areas. Then another thing would be inflammation, especially chronic inflammation. It can also lead to high glucose levels. And then lastly, we would have diminished satiety. When a patient has diminished satiety, they tend to eat a lot of food, and then they do not know when to stop, and that can also lead to weight gain and then eventually hyperglycemia. The diagnostic tests that we use, one is the glycated hemoglobin, which we also call the A1C. We can also do the fasting plasma glucose, and the fasting has to be more than 8 hours. And then we also have the 2-hour plasma glucose after an oral glucose tolerance test. So for patients with diabetes, if their A1C is above 6.5%, that patient is usually diabetic. If their fasting plasma glucose is equal or above 7 millimoles per liter, or if the 2-hour glucose after the oral glucose tolerance test is more than 11.1 millimoles, then we confirm that patient as having diabetes. Then for A1C is usually between 5.7 to 6.4. The fasting plasma glucose is between 100, that is in milligrams per deciliter, to 125. And then for the oral glucose tolerance test, it's between 140 to 199. So what we need to know is that the plasma glucose values, that is from the fasting plasma glucose or the oral glucose tolerance test, they have a greater diagnostic accuracy than the A1C, especially in those patients with discordant values. By discordant, I mean values if the A1C value is not elevated, but these plasma glucose values are elevated. So there is a difference. That means you take the plasma glucose values rather than the A1C. But however, it is important to note that A1C is more convenient because you do not have to fast, and you won't even, it is not affected by fluctuations or disturbances in glucose fluctuations or disturbances, like things like stress, if the patient has had a heavy carbohydrate diet, or illness. All these do not affect the A1C. And it basically measures the average blood glucose over 3 months. That is why it is more convenient compared to the other ones. But if, like I said, if there is evidence of discordance, then you take the plasma glucose values. When an underlying cause is suspected or known, then these can be used to diagnose the glucose values. Blood glucose values can be used to diagnose. More about the glycated hemoglobin. Like we said, it measures the percentage of glycated hemoglobin in blood, and therefore it is an indirect measure. And also, it does not provide information regarding the fluctuations I've been talking about. So what we need to know here is that hemoglobin, for example, if there are abnormalities in hemoglobin, they may either increase or decrease this value. So we need to be careful, especially when we are looking at our patients with diabetes. So things like anemia, severe hypertriglyceridemia, chronic alcohol consumption, all these tend to increase the A1C, while things like blood loss, hemolytic, acute and chronic blood loss, hemolytic anemia, even patients with end-stage disease and pregnancy, all these tend to falsely decrease the A1C. So in that case, the glucose values tend to be more accurate. So I added this table. I don't know whether it is very clear, but I added this because it is very important when you evaluating your patients in areas where you're not able to get some of the values, the A1C values, or if you have the A1C values but you cannot get. So these are just estimates of A1C in terms of percentage, and then the corresponding values of glucose levels. So 5 tends, it is usually around 5.4 millimoles with a confidence interval between 4.2 to 6.7. So this can be very important in case you want to make clinical decisions, but you are not able to access the glucose values. And then also tend to understand these blood glucose values better than the A1C. So this is a very important table that you can maybe keep. So in terms of screening for diabetes, we screen patients, we screen adults with overweight or obesity. That is if they have a BMI greater or equal to 23 kilograms per meter squared or 25 kilograms per meter squared. And those who have either some of these risk factors, for example, if they have a relative, a first degree relative who had diabetes, if they have a history of cardiovascular disease, if they are hypertensive, if their HDL cholesterol levels are below 35 milligrams per deciliter, or they are physically inactive, all these need to be screened for diabetes. So, and people with pre-diabetes, those usually between 5.7 to 6.4 for A1C, should be tested every year to see whether they are now diabetic or not. Even those who are once diagnosed with gestational diabetes mellitus should be tested at least once every 3 years. And then for all other people, we should be screening them for diabetes once they reach the age of 35 years, as well as people with HIV and those receiving high-risk medicines like glucocorticoids or antiretrovirals as well should be screened. So this is a screening tool, one of the screening tools from the guidelines, and it is it can be used even to assess yourself. So you answer these questions and then you add up the score, and if it is 5 or higher, that and therefore you would need to go ahead and do the tests that we've been talking about. So the general approach to treatment, we have, you need to do a comprehensive medical evaluation, and this is usually done during the initial visit. And we do it so that we can confirm diagnosis and be able to classify. Someone asking something? Yeah, so we need to, we do it during the initial visit to either confirm and classify. We also want to evaluate the complications of diabetes that have already occurred. And then look at also potential comorbid conditions, as we shall see in the management. It is very important, and also assess the overall status. We also do it to identify care partners, and the support systems that we have. We shall briefly look at the care model towards the end of this presentation. And also, it is very important for us to assess the social determinants of health in these patients, things that might prevent them from seeking care in the facility. It's very important. Then we also want to look for previous treatment and risk factor management in people with established diabetes, and also begin engaging these patients in the formulation of their care plan, and then to develop a plan for continuing care. An important point here I felt that I should add, because the world is changing, and so should we. We need to be able to use empowering language in these patients. Language that is neutral, non-judgmental, and based on facts, actions of physiology and biology. All this helps us to prevent stigma in these patients and to be able to achieve our goals. Okay, so we also need to use person-centered language that is person-centered. For example, we say a person with diabetes. We no longer say a diabetic patient. I know it will take time for us to catch up, but we need to. So in terms of evaluation, like we've already talked about, you need to assess some of the risk. You assess the risk of complications. For example, if the patient has atherosclerotic vascular disease or heart failure history, you do a 10-year SCVD risk assessment, and then you do staging for chronic kidney disease if they have. You assess for hypoglycemic risk, especially in patients who are elderly, or those who are receiving drugs with a high threshold of causing hypoglycemia, things like sulfonylureas or insulin as well. Then you also assess for retinopathy and neuropathy, and then you also assess fatty liver disease, non-alcoholic fatty liver disease as well. Then you also need to set goals at that time in terms of their in terms of either AA1C or blood glucose levels. And if hypertension is present, you also need to establish the blood pressure goal. And you also need to manage the weight and also physical activity goals. So we also do referrals at this point. We need to refer them to ophthalmologists for eye exams. We also need to do counseling, especially on family planning. We can refer them to those specialists, nutritionists as well. And then we also emphasize self-management for these patients. Behavioral health professionals should also be consulted in some patients. So in other words, we need to routinely screen, especially for depression among these patients and other mental health issues as well, and the rest also. So the primary goals of therapy for diabetes mellitus, one is we want to prevent or either delay acute or long-term complications in these patients. And then additionally, we can try to make sure we alleviate the symptoms that they have. We want to minimize, as we are making our treatment, we want to minimize hypoglycemia as much as possible because it is also equally fatal. Then we also need to minimize treatment burden, okay? And then maintain quality of life. So to do all this, we need to make sure we control our glucose levels well and also the comorbidities. So in terms of specific goals that we need in these patients, for most patients, we need A1C less than 7. And then for some patients who are at risk of hypoglycemia or they have limited life expectancy, a goal of 8.0% is usually okay. And then for pregnant patients, then we need to be more stringent. Usually anything less than 6 is what is desired, but we need to be careful. We need to do that in putting into context that we may also cause harm to the patient and their unborn child. So in terms of us monitoring the treatment, we normally do A1C, and this is done for patients who are stable. We do it at least twice a year. And then those who are getting either fluctuations in terms of hypo and hyperglycemia, we do that more frequently, at least every 3 months. And then we also do preprandial and postprandial glucose measurements, especially if they are done by the patient at home, it would even be better than having the patients coming to the clinics. In terms of non-pharmacologic therapy, diabetes self-management and education is very key because this helps them to make the patients to make informed decision making and then also improve their self-care behaviors. So it is very important. You need to empower these patients to be able to self-manage their condition. Then we also give individualized medical nutrition therapy. And here we tend to promote and support healthy eating patterns, emphasizing a variety of nutrient-dense foods in the appropriate proportions. Then for salt, we normally recommend that they consume less than 2.3 grams a day of sodium. And then alcohol is also important, that we minimize alcohol consumption because it can actually cause a delayed hypoglycemia in these patients. Sweeteners as well. It is important to avoid these in patients with diabetes. Then we need to help them stop smoking, both that is either tobacco, e-cigarettes, or cannabis. They need to stop. And then psychosocial care is also important. Like I said, depression is very prevalent among these patients. So it is important that we do not ignore psychosocial care. Physical activity as well is recommended. I think it's about a total of 6 hours a week. That is 2 hours a day for 3 days in a week. A total of 6 is usually what is recommended. A healthy sleep is also important. So you want to counsel them on sleeping routines, things like maintaining a constant sleep schedule. If they sleep at 10, should always ensure that they sleep at that time. If they sleep at midnight, it should be at that time. And also, you want to tell them that they should not be taking caffeine, especially from midday onwards. They should not be taking any caffeine. So the therapy for pharmacological therapy for adults with type 1 diabetes. So for most adults, the insulin analogs are usually preferred. So the subcutaneous insulin infusion or multiple daily doses of prandial and basal insulin are what we normally use in these patients. Then the insulin analogs are usually preferred over the injectable human insulins. And also what is very important here, you need to start using continuous glucose monitors at a very early stage. So these products are available in Uganda. They are still quite expensive, but the earlier you start using them, the better the treatment outcomes for the patients. Also, automated insulin delivery systems are now available. I don't know if we have any in the country now, but it is also one of the ways for treating these patients with type 1 DM. You need also to educate them on how to match their mealtime insulin doses with the carbohydrate intake, and as well as to their fat and protein intake. They should also be taught on how to modify the insulin dose based on their glucose levels. And also if they have the trends, most of these patients we see, they normally have their books and they have their glucose readings from home. So if you can also train them on how to modify their doses based on those trends, then it would be very important. So for adults with type 2 DM, the American guidelines recommend that the plan should always consider approaches that will support weight management in these patients. And if patients come in with if you need to achieve your target within a short time, you can consider early combination therapy, especially those who come in with high glucose levels. And those patients with a high risk of atherosclerotic cardiovascular disease or heart failure or CKD, you should have agents that have been shown to improve or to reduce the risk of cardiovascular or kidney disease. Things like the SGLT2 inhibitors and the glucagon-like peptide 1 receptor agonists. So this is an algorithm. I'll try to make sure it is visible for treatment of type 2 DM. So usually for patients who are pre-diabetic patients, you want to encourage healthy lifestyle behaviors, self-management, you want to educate them. And then also patients who come in for the first time, you want to do all that. And then the first line treatment is usually metformin. or some other agents like sulfonylureas can also be used. But in Uganda, we use metformin as the first line treatment. So if the A1C is greater than 1.5 above the target, so if we said our target is for most patients is less than 7. So if they come in with an A1C greater than or equal to 8.5, then there you can consider combination therapy. And what we normally use here is metformin with N-sulfonylurea. Then if the A1C is greater than 10% or of the target, no, if it's greater than 10%, then and blood glucose greater than or equal to 300 milligrams, then you can start insulin therapy, and we shall see that. So after that, you reassess your plan after 3 months, and in reassessment, we said you look for A1C, or you can look at the patient's blood glucose levels. Then you want to establish whether this patient has a high risk of any of these three: heart failure, kidney disease, and vascular disease. So if the risk of vascular disease is high, then you can consider glucagon. You can consider glucagon-like peptides. Sorry about that. So you can consider glucagon-like peptide 1 receptor agonist, or sodium glucose transporter 2 inhibitors. And we've already seen where these drugs work. So these drugs have a proven cardiovascular disease benefit. And if the A1C is still above target, then you can consider adding another. So you consider, for example, if you are already on a GLP-1 receptor agonist, you can now consider using the SGLT2 inhibitors, and vice versa. You can also consider using a low dose thiazide. For example, things like pioglitazone can be used in this case. But what is important to note that they should not be used in patients with heart failure, like we shall see ahead on some of the adverse effects of the drug. Then in heart failure, the SGLT2 inhibitors have those with benefits. Not all of them have cardiovascular, have benefit in patients with heart failure. Then you also want to avoid, like I already said, the thiazoline diones, and then sasagliptin as well cannot be given in these patients. In those with a chronic kidney disease, again, SGLT2. So these patients, usually you find that either they are hypertensive. Even those who are not hypertensive, you find that they have proteinuria. So there is usually a warrant for use of ACE inhibitors or ARB inhibitors. So if they are well tolerated on these, then you can add an SGLT2 inhibitor. Those, again, those with evidence for reducing CKD progression. And we shall look at them. Okay. Yeah, they are actually here. So you'll get these slides. I'll share them. But this shows the class of drugs that have shown benefit in each of these comorbid conditions. So it would be important to take note of those. Okay, so if the patient does not have any of those comorbid conditions, then now you select therapies with adequate efficacy and those that will help you maintain the treatment goals. Okay, so this is just things you need to consider. You need to consider the cost of the drug. You also need to consider if they are effective in weight loss, and then also their efficacy in lowering the glucose. There are those with a very high efficacy in lowering glucose, things like insulin, semaglutide, and dulaglutide, high dose, are very high and efficacious. Then those that are high, the GLP-1 that are not mentioned here, the metformin, SGLT2 inhibitors, sulfonylureas, and the rest. So you need to put into consideration all these when you're choosing. And if the target is still not achieved, if the A1C is not achieved, then you can add, you look at other factors for the patient as well.
Let's get
So
something
things like
to eat.
adherence and the rest. Okay, I will share these and you'll be able to look at these protocols clearly. So for patients that you want to start on insulin directly, so those with A1C greater than 10%, you want to first you want to first look at other injectable therapies that can be used before you go for insulin. So things like the GLP-1 receptor agonists can be used before you use insulin. But if still you do not achieve, then you can now add basal insulin in this case. So it's unlike type 1 where you're having both basal insulin and then prandial insulin, postprandial insulin or preprandial insulin, depending. So here we normally want to start on basal insulin before we can move on. And you want to titrate, you start with low doses, 10 units a day, or you can use between 0.1 to 0.2 units per kg per day of basal insulin. And it is usually recommended that we give it at bedtime. Okay, yeah, so you'll go through the rest of this as well. Okay, so I've already hinted on some of these. Insulin, the onset, the peak, and duration varies by the type. So we have short-acting insulin, rapid, we have mixed, and then long-acting. And all these have different peaks, as well as onset, and then the duration. So these are important for us so that we are able to select the most appropriate. For example, in diabetic acute complications, things like DKA, you probably want to choose a short-acting over a long-acting agent. And then in terms of selection, I've already hinted on this, that in type 1, we normally do basal and then bolus as well, pre or postprandial. Then in type 2, we normally do basal insulin initially before you can go on. So another thing you need to put into consideration is the cost of the insulin, especially in our setting. We know the intermediate acting, which is NPH, is the most common here, and it is quite cheap. The only disadvantage is that you might need to give it 2 times a day because it is intermediate acting. If you can try to locate it, it usually peaks within 5 hours, and then the duration of action is about 12 to 14 hours, around there. So it is important to consider those as well. So this is the same as what I've been talking about. These are the different types. These are their peak hours. Yeah, and then peak hours and then duration of action. But we see here we can use NPH as basal. We can use NPH as basal insulin, and then sometimes we have what we have here is mixed, which is usually a combination of regular insulin and the intermediate acting NPH. Okay, so this table is a summary. It's not so clear on my end, but it is a summary of the drugs. And I think I will leave this and I'll just highlight a few things. In terms of benefits, in terms of efficacy, metformin is high. It does not cause hypoglycemia. In terms of weight change, it is neutral, but some cases have been reported for modest weight loss. And then in terms of cardiovascular events, effects, in terms of heart failure, it is neutral. Progression of kidney disease, it's neutral. But what we need to note here is that it is contraindicated in patients with kidney disease with a GFR less than 30 mils per minute. So in these patients, and the reason is because of the potential to cause lactic acidosis. Even in some physicians usually advocate that it should not even be given in patients with patients who are within the hospital stay because of the potential to cause lactic acidosis. Okay. The common side effects are usually GI related, but it has the potential to cause a B12 deficiency. So we normally tend to monitor B12 levels. And it is also relatively cheap. Then we also have SGLT2 inhibitors. These have benefit cardiovascular, in terms of cardiovascular effects. They have proven benefit and also benefit in terms of progression of kidney disease. They reduce the progression of kidney disease. And these are the three: canagliflozin, dapagliflozin, and empagliflozin. Okay, so again, for considerations, these can be used. Majority of them can be used in patients with kidney disease, but usually patients with a GFR less than 15, you do not want to use. But however, if the patient has already been on the drug and then the decline, the GFR of the patient declines below 15, you can still maintain them. But newly diagnosed kidney disease, you do not want to start all those with already a GFR less than 15, you do not want to start the SGLT2 inhibitors. So the other one is the glucagon-like peptides. Glucagon-like peptide 1 receptor agonists. These have cardiovascular benefit and also benefit in terms of reducing, slowing down the progression of diabetic kidney disease. Yeah, but we need to monitor renal function, especially when you're trying to initiate, because some adverse effects have been reported. So majority of these drugs are subcutaneous, but semaglutide has both oral and sub-Q formulations. Okay. So I will jump to the thiazolinediones. These also have a very high efficacy of lowering glucose, but they cause weight gain. Okay, and then basically usually neutral benefit in terms of kidney disease. Pioglitazone has potential benefit in terms of cardiovascular disease, and then they are contraindicated in patients with heart failure. So what these drugs do, they usually enhance sensitivity of insulin in either the muscle, liver, or fat tissues. And one of the adverse effects for these drugs is that they can cause edema. They can also worsen or even cause a new onset of heart failure as well, and even bone fractures. They normally cause fluid retention because they cause the vasodilation in the kidney, and then they also improve insulin sensitization as well in the kidney, and then you'll have an increase in renal sodium, and therefore more water will be retained. So that is why we want to avoid them. One, I think it was Jasper, if I may recall, he consulted on a case about a patient on diabetic nephropathy, and that patient, I remember, was on pioglitazone, glimepiride, and metformin, and that patient the patient's edema was not improving. So this is one of the drugs that could have been a culprit in that patient, and therefore it would be important if that drug is stopped and then the diuretics are maximized. So the final drugs are the sulfonylureas. I can move to the next. So the sulfonylureas act by increasing insulin secretion from the beta cells. For it, one of the things you want to watch out for is the sulfonylurea-induced hypoglycemia. They cause hypoglycemia, but specifically sulfonylurea-induced hypoglycemia is quite difficult to manage. Instead, it does not usually respond to glucose, giving glucose. So in those patients, we normally tend to give octreotide to fast before you octreotide alongside with glucose as well. And then so yeah, I brought back this to basically show the mechanisms of actions of how they work. What we've been discussing, I think, is all captured here. Maybe another drug I had forgotten. For example, the DPP4, dipeptidyl peptidase 4 inhibitor. Specifically, sasagliptin has an increased risk of heart failure, and that was in the SAVA-TIMI trial. So you want to avoid this drug in those patients. So patients with diabetes, you want to assess for hypoglycemia or the risk of hypoglycemia. Whenever they come in, you want to make sure you review if they have any history of they have had any history of hypoglycemia, especially for those at increased risk. You screen them also for if these patients actually have hypoglycemia awareness, can they be able to tell when they have hypoglycemia? Then glucose, of course, is the preferred treatment for all patients who are conscious. And if they have their blood glucose levels less than 3.9 millimoles per liter. Although any carbohydrate can be used, but we usually prefer to use glucose. So if hypoglycemia persists after 15 minutes, then you repeat the treatment. Glucagon, these are recommendations from the current American Diabetes Association guidelines. They say that glucagon should be prescribed for all individuals, and you should take it that you should make sure you educate the patients on the use. For all patients who are receiving insulin, you have to prescribe glucagon for them, and as well educate the caretakers and the patients themselves. Yeah, again, education is coming up. So hypoglycemia, in terms of classification, it is 3 levels. Level 1 is when you have glucose levels less than 3.9, but greater or equal to 3. And then anything less than 3 is level 2. And then level 3 is when a severe event, which is either characterized by altered mental or physical status, that requires assistance for hypoglycemia, irrespective of the glucose level, then that is a level 3. And this is important because it is able to give you a picture of either the treatment, maybe the treatment is too aggressive, or the patient is not taking it the right way, the insulin the right way. So that is important. So I'll try to go through these very fast. In patients with cardiovascular disease, you want to make sure you do lifestyle modification and educate them. The goal here, the BP goal is usually in patients with maybe hypertension and diabetes, is less than 130/80 milligrams per milligrams of mercury. And then ACE inhibitors, and angiotensin receptor blockers are the first line therapy for these patients. And then for patients with urinary albumin and to creatinine ratio greater than 300 milligrams per gram, again, you want to make sure you give ACE inhibitors or ARBs to reduce protein. Then for hypertension, again, this is if the BP is above 130/80 but less than 150, usually we start with 1. agent. If the patient has albuminuria, then you start with an ACE. If they do not have, again, you can choose from any of these, either an ACE or a calcium channel blocker or a diuretic. But lifestyle management is the cornerstone. If the BP is above 150, then we start with 2 agents. And if they have albuminuria, you start with an AC, has to be a must, and you can either add an AC or an ARB, and you can either add a diuretic or a calcium channel blocker. If they do not have albuminuria, you can start with any of those 3. And then you assess the BP control, but you also look out for the adverse effects. If the treatment is well tolerated, you continue, and as well if your target is being met. If it's not being met, you can add an agent. If they have an adverse effect, for example, in ACEs or ARBs, you can switch as well. Then for kidney disease, you need to screen for the complications of chronic kidney disease. For example, it can lead to blood pressure, fluid overload, and make sure you manage all these: metabolic acidosis, anemia, and as well as bone disease. And you make sure you manage those appropriately. Then in terms of management, again, we start with lifestyle, and then first line drug. We've already talked about this, the SGLT2 inhibitors and metformin. But for metformin, you do not give if the eGFR is less than 30. A RAS inhibitor can also be given in these patients if it is tolerated. Because we know these RAS inhibitors as well can cause AKI. So again, we do not give them in patients with eGFR less than 15. Then you need to also give in these patients moderate or high intensity statins. Then you need to do regular assessment. And in terms of regular assessment, you're looking for glucose levels, albumin levels, BP, if there are any cardiovascular risks, and lipid profile as well. And then you may give any additional therapy, any of these, based on the comorbid conditions that you encounter. Okay. So someone in the chat is saying I should talk about DKA. I will also rush through this because of time constraint. But DKA is usually as a result of severe insulin deficiency, and then an excess of the counter-regulatory hormones like glucagon, epinephrine, cortisol, or growth hormone. The precipitating factors is usually failure to take insulin or failure to increase your insulin when it is indicated. For example, in cases of infection, pneumonia, another precipitating factor would be illness or infections, things like pneumonias, MI, stroke. All those can precipitate DKA. And also things like acute stress, medical stress, and hypovolemia. All these can precipitate ketoacidosis. This was basically about how it comes about. You have insulin deficiency. There is a decrease in glucose uptake by the tissues, then you will end up having high blood glucose. And then also this insulin deficiency can cause an increase in proteolysis, and then you have amino acids leading to gluconeogenesis and glycogenolysis, breakdown of glycogen, and you end up with glucose, increasing the hyperglycemia. So what that does, if glucose levels are high, you'll have osmotic diuresis and eventually hydration. So these patients tend to present with a lot of dehydration. But also, if insulin is deficient, there will be an increase in the breakdown of lipids, and therefore you would have an increase in fatty acids and glycerol, and these fatty acids usually lead to ketogenesis, and that is what is usually responsible for the acidosis, the ketone bodies that are produced. In terms of diagnosis, you want to do urinary ketones, and also you want to do pH and electrolytes as well. So in these patients, usually the urine ketones are positive, and then there might be deficits in terms of water. You will have dehydration, sodium and potassium as well. And then, of course, the blood glucose levels are high. So the signs, these patients tend to have polyuria, polydipsia, and even urinary incontinence, especially in children. And then dehydration, they tend to also come in with tachycardia and orthostasis because of the dehydration, abdominal pain, and then they tend to have a fruity breath, and then kusumo breathing as well, and mental changes, especially some coming with coma. So this is the management. So when we are managing DKA, there are about two or three things that you need to be aware of. One is that this patients come in when they are dehydrated, so you want to rehydrate. So the choice of fluid, usually we tend to use normal saline, and in this case, it is advocated that we use half normal saline instead of our usual normal saline in these patients. And also, what used to be controversial was whether or not we should give Ringer's lactate. But from evidence, it shows that we can give this Ringer's lactate because it might help as well in terms of the potassium replacement, but also the cause of the acidosis is usually because of the ketone bodies and not necessarily because of the lactate. So we can also give Ringer's lactate in this case. New evidence now shows that it is okay to be given. Then the other one would be you want to check for potassium levels. And the reason we are doing this is because we want to give insulin, okay? So you want to check and then adjust. Sometimes you will have to first replace. If there is a deficit, you replace, okay? If there is no deficit, then we can now give our insulin. And insulin, we normally use the infusion, IV route, okay? Unless if it's uncomplicated, then we can use subcutaneous route. But if it's complicated, then we have to use, and most patients present in a emergency, that present in an emergency situation are usually, most of them are usually in coma and things like that. So we want to give IV and IV, okay? And the choice, we normally give regular insulin at 0.1 units per kg. We can give a bolus, and then we continue giving 0.1 units per kg per hour as a continuous infusion. So what we want to do in here, you want to check, as you're giving insulin, you check your anion gap. Okay, so anion gap is basically the difference between those anions and the cations. Okay, the chloride and the bicarbonate, then the sodium and the potassium, the difference. So because of the acidosis, so you want to make sure as you're giving, you make sure you close the gap. So if that gap is now closed, then you can switch to a bolus. Okay, and if your blood glucose levels fall below 200 milligrams per deciliter, then you can add D5 in this case. Okay, you can still add a D5 even when it falls below 200, because we are giving insulin not because of the glucose levels, but because of the ketoacidosis, and we are giving it until we make sure we do not have the ketones are reduced. So again, if your pH, anion gap is closed, but your pH is still less than 7 or 6.9, then you can add a bicarbonate. But this has been controversial as well. Some say you should not give the bicarbonate, but others say you need to add the bicarbonate in that case. Okay, so I think that summarizes the management of DKA, and I'll just briefly talk about, because this is a chronic illness, so it is important that our treatment is tailored to the chronic care model. Okay, so this model just it aligns approaches to diabetes management. You need to align your approaches to the chronic care model, and this model emphasizes person-centered care, integrated long-term treatment approaches to diabetes and comorbidities, and ongoing collaboration and communication by setting goals with the patient. You make sure, for example, you explain to them, now we want to achieve A1C less than 7. This is what it's going to take, and things like that. So you need to also tailor their treatment to the social context. You're basically looking at things like of food insecurity, housing. Are there any financial barriers? Are they able to get support from the community? Things like that are quite important. So the role of the pharmacist, again, care plan. You want to collect subjective information. We've already talked about the patient's history of the symptoms, what level of glucose control in this patient. You want to understand their medication use. I mean, are the patients understanding do they have an understanding of medication use? What's the disease state? What are the lifestyle modifications that they are currently on? And then what is the patient's current medication use? Are they adhering or not? What about the diet and then exercise information that they may have? You want to look at the recent maybe screenings or appointments or examinations. And then objectively, you want to, of course, measure the blood glucose levels, the A1C, the blood pressure we saw, and pulse, lipid panel, the renal function as well, electrolytes, and a comprehensive diabetic foot examination. Then in terms of your assessment, you want to look at the current level of control of the diabetes. Are there any, you look out for the necessary lifestyle modifications, their current medication use, and you also need to critique the use and things like that. So you look out for all these, and for medication use, here the patient is usually a candidate for educating them on appropriate medication and the doses, selecting the appropriate medication, you selecting the appropriate medication and their doses, then also a comprehensive and preventive care needs and their education needs, because you will be implementing some of these. So in your assessment, you should be thinking about this. You should also think about their comorbid conditions, blood pressure, if it is well controlled, do they need any further education? In terms of cardiovascular risk, do they also need the lifestyle modification, any other education needs that they need? And then you plan for diabetes. Your plan should include lifestyle modifications, educate them on the diet, the weight loss, regular exercise, the moderate or no alcohol at all, stop smoking, then how they are using their medication, how they can be able to monitor their disease state, and also a comprehensive and preventive care, and you provide education, and you look at the comorbidities as well. So that marks the end of my presentation. I can take some questions.
Thank you, Doctor, for that wonderful presentation. It was very comprehensive. I think it has enriched our knowledge on management of diabetes, the role of a pharmacist in such level of care. So I think it's time for questions, and the mode of questions will be, if you have a question, you either use the chat or you raise your hand and air it out. So I think we'll start with questions. I think I will start with mine. Mine is a little clarification on the pathogenesis of insulin resistance. I read somewhere, and they were trying to connect it to increased abdominal fat, and I didn't understand it well. So if you could clarify on that. And I have about 3 personally. The second one is, which drug should be given to newly diagnosed patients with diabetes with the eGFR less than 15, because most drugs seem to be contraindicated in renal failure, especially at that level. And the last one is the foods we should recommend, because usually they tell us to refer to a nutritionist, but they are not very common in our settings, and we find ourselves having to do the job of a nutritionist. And in our settings, we find the common foods are all rich in carbohydrates, so we don't really know which ones to give. Then let me look through the chats. Shamim Nambasa also says she has seen some literature on contraindication of sulfonylureas, glibenclamide in eGFR less than 60, Please comment on that. And Dr. Kings is asking you to elaborate on the rationale of using potassium. I think they usually give potassium chloride with insulin. So I think let's start with those, and maybe we shall continue with the others. Sure, because I see no hand raised so far.
Okay.
Doctor, you there?
Yes. I will start with the rationale of insulin, of giving potassium.
Yes, potassium.
Maybe if I can go there. If I understood the question well, she wanted to know why we're giving potassium and insulin as well. So insulin causes an influx of potassium from into the cells. So the potassium is moving from the blood into the cells. So that causes hypokalemia. So, and hypokalemia can cause a variety of, it can cause very many issues, because we know potassium is very important in the electrochemistry of majority of the organs. And what we are particularly worried about is the heart, okay? Because it may cause arrhythmias, and then, so since we are going to be giving a lot of insulin here, you want to make sure it is maintained within normal range. So that is why in that case we give insulin alongside with potassium. And the values are here. We keep monitoring. If potassium is usually above, if potassium is above 5.3, there we do not replace, but we keep checking every 2 hours. Then if it's between 3.3 to 5.3, then we can give around 20 to 30 milliequivalents in each liter of IV fluid, as you're giving the IV fluid. And if it is less, we give more, usually up to 40 milliequivalents of potassium in that case. Insulin resistance, there are very, very many mechanisms surrounding insulin resistance. But as you rightly said, abdominal fat is one of those that studies have identified as one of the reasons why we tend to have insulin resistance. One of the pathologies of insulin resistance. They say that the abdominal fat is a bit, I think, harder. It's in lay terms, I may say, harder to break down. But yes, you're right. It is one of the pathophysiologies of insulin resistance. Then the other one was I think you had talked about the drug. The drugs that we can give in GFR less than 15. Is that right?
Yeah,
you
less
can.
than 15.
Yeah, you can give insulin can be given in these patients, but it needs to be monitored and adjusted accordingly. So these patients have to keep monitoring their glucose levels, because we know in these patients, we know insulin again is secreted by the kidney. So in an impaired kidney function, you expect to have it being in the blood for a longer time. So it is important to keep monitoring and adjust doses, and they're usually low doses that we give these patients. So I think in the table, if I can go there. Okay. So in this table, we see thiazolidinones can also be can also not be given. Okay, so I think here it is safe to say we can only give insulin and maybe your SGLT2 inhibitors. If the patient is already on those, they can continue with that, but that would be the most appropriate.
Doctor, there were two other unaddressed questions. The question on feeding for patients with diabetes, and the question on sulfonylureas being contraindicated in diabetes, sorry, in renal failure. I think that has been answered, but mostly the question on which foods are easy to give. You know, like in our setting where we have mostly carbohydrate-rich foods, which ones do we choose in such a case?
So that's a whole lecture, the diabetic diet, but usually, if I may, yes, so in patients with so in these patients we have the DASH diet that is usually in hypertensive patients, but in these patients, like you said, you want to draw your plate and you have the basic understanding. You have a third, okay? You divide it into four. A half of the plate should be, I think, greens, vegetables, and the likes. Then carbohydrates should just take a quarter, not a third, but a quarter of the plate. And then proteins should also take. Proteins can take the remaining quarter. So in a basic nutshell, but I know there is a lot of literature on that, which I have not really read much on, but in a nutshell, that is how you would divide your plate.
Thank you for that response. I think there are some more questions. Someone asking,
Yeah,
is there a
I'm
relationship
seeing
between?
some. You're saying? Okay, go ahead.
Is there a relationship between insulin resistance and erectile dysfunction? And Nalija was asking for clarification on how to differentiate between DKA and HHS. And then I see another one asking how the morning and evening doses of insulin mixed are determined.
Okay, so I see some of those have been already answered in the chat. Is that right?
Yeah, some of them have been answered. Let me see.
Yeah, like the insulin dosing has already been answered.
Yeah, that's true.
Okay.
But the relationship between insulin resistance and ED and the clarification on the difference between DKA and HSS.
DKA and HHS. Okay, just a minute. So as I look up something, I wanted to project something else, but I can't seem to find it. But what we normally see in DKA, one of the differences, all of them you have hyperglycemia, but in DKA we have we have ketone bodies, while in HHS we do not. Okay. I think I am about to get it. Let me just share this. Okay. So these are the differences between the two. Okay. But the notable ones is that here you have ketone bodies. Here you do not have ketone bodies in HHS. Then HHS usually it is an insidious onset. It takes some time, while decay is usually rapid. And in HHS, we also don't get to see the acidosis. Well, here we have usually severe acidosis because of the ketone bodies. We tend to see the ketoacidosis. But in both, there's a lot of dehydration, and DKA is also more common in patients with type 1 diabetes or type 2 diabetes is dependent. Patients who are dependent on insulin, we tend to see it in those patients. Then the anion gap is usually more than in DKA is usually more than 7, while in HHS it is less than 7. Yeah, and then the rest of these as well. I don't know whether that answers the question partly.
I think it actually fully answered it.
Someone is saying DK is in type 1 and HHS. That's not true. Okay. DKA can be both in type 1 and it can be in either type 1 or type 2. Okay. What was the other one? Insulin resistance and erectile dysfunction.
Yes.
Well, I'm not aware of this, but what I see is that, I mean, the mechanism for erectile dysfunction in this patient is when you have uncontrolled blood glucose levels that are affecting the supply of blood, okay, to the erectile organs, okay. But the relationship between insulin resistance and, I'm not aware of this. I'm not sure there is a direct relationship between the two, but the diabetes itself could be a confounder in the relationship. Is there any other that I have not talked about? I'm trying to look through the charts to see if there's one that I could have missed. Okay, so I think that is it.
It seems to be it. There's also still no other hands up. So I think we'll have to get into the next segment of the meeting, which is the very last segment. I see one more question. Let me see. Yeah, it has a thank you. Yeah, it has a thank you. So the next and very last segment of the meeting, which is the closure of the meeting, and we'll do this by first of all thanking everyone who has participated in the meeting. So it feels good when you're presenting to hundreds of people, and thank you for showing up. Then thanks to all the AIPU executive committee members who do all the work to have this meeting, in place, and to the Pharmaceutical Society of Uganda for always providing the link that we use for these meetings. And most importantly, to our presenter, Dr. Kyomya, for the wonderful knowledge that he has imparted into us. We believe it will change our practice for the better, and it will be impactful in the paper. We have a belief that number of diabetes is coming, and we shall crush it with the knowledge we've been able to attain in this particular session. Thank you so much for your time. We appreciate it, and thank you again. Thank you. So I will beg to close the meeting. We hope to see you in more and more meetings of this nature. We've heard you have a particular interest in kidney failure, and we haven't done a CME on that. So possibly if we could have one on kidney failure, because it seems to be a very common condition, and both on words and in the question papers, we would be glad to have you. But thank you so much for your time on this, and really appreciate. I will beg to close the meeting. Thank you and have a good night.